a little dizzying, isn't it? Well, that's a quick overview of the entire case. We can slow it down a bit now. Okay. My goodness, where to begin? Well, I'll tell you where to begin. Right here. When you see something like this, it's sometimes hard to know where to begin describing it. In this case, what we're looking at is a hypertensive hemorrhage. And they nearly always occur in the basal ganglia. So this one is centered in the basal ganglia. So the primary event then is right here. So that's where I would start out. And I would make a simple statement like there is a very large hematoma in the left cerebral hemisphere centered in the region of the basal ganglia, period. There is intraventricular extension. How do I know that? Well, first of all, there's blood in the ventricle, so is it possible there was a separate hemorrhage that occurred primarily in the lateral ventricle? It's possible, but unlikely. And if you look closer, you can see that this hemorrhage is in very close proximity to the lateral ventricle in some areas, and therefore likely is communicating in that manner. And this looks like a very suspect point right there. So, hypertensive hemorrhages tend to occur in the basal ganglia because, as you know, the middle cerebral arteries go off to the right and to the left, and we get a little hint of them here, partly because of their own natural high attenuation and partly because there's some blood probably tracking along the vessel from the subarachnoid space. So this huge hemorrhage occurs because of hypertension, and the pathophysiology appears to be that this MCA vessel on each side has very thin branches that course superiorly. Okay? So you don't see these because they're too small. But along this length of middle cerebral artery, and by the way, it's important, I think, to know that this proximal segment of the middle cerebral artery, before it branches, is called the M1 segment. So if you want to go from good to great, describe this as the M1 segment of the left middle cerebral artery. And it is from that M1 segment that these little perforating vessels emanate and course upward superiorly, and they become friable with time, particularly in patients who have hypertension. They undergo some pathologic changes in their wall which predispose them to hemorrhage. So besides having the changes in those very small perforating vessels, those small perforating vessels that are coursing superiorly from the middle cerebral artery, you have the high blood pressure itself. And with time, the two add up to an explosive event like this. This is about as big as it gets, and that for us is going to be helpful in understanding some of the mass effects that we see in the head. The fact that there's intraventricular extension just means that things are going to be all the more tighter, because in so much as the ventricular system, mainly the lateral ventricles, have fluid in them, and they can be squeezed down without getting immediately to the point of injury to the brain substance. Now you're filling up the ventricles with blood, and so they are not able to compress as easily as if they were filled with just CSF. So going through where we see abnormalities, then huge left basal ganglia hemorrhage. And there is intraventricular extension with a large amount of blood in the lateral ventricles, and here. Where is that? That's a ventricle. It's the third ventricle. So the blood is going from the lateral ventricles and the frontal horns of the lateral ventricles kind of come forward like that, and then they duck down together and meet right here where they empty into the third ventricle. So you have a foramen of Monro on both lateral ventricles going into the third ventricle. So the blood empties from the lateral ventricles through the foramina, the plural, the foramina of Monro, into the third ventricle. Okay, now where's it going to go from there? What little channel connects the third ventricle to the fourth ventricle? It is the cerebral aqueduct. And you can make out a little bit of a hint of it there. So here we are in third ventricle. You go down, and it's somewhere in there, but it's very severely compressed. I think you can see that. We'll come back to that. And go down a little inferiorly. And here we are in the cerebral aqueduct, and it should be opening up, and indeed it is, to the fourth ventricle, immediately caudal to that. Remember, rostral is upward and toward the top of the brain, and caudal is downward, and those are terms. You can still use superior and inferior, and I do when it's within an area of the brain. But I would describe the brainstem not so much as inferior to the cerebral hemispheres, but caudal, because it specifically alludes to that axis from the hemispheres to the brainstem. So here we have blood in the fourth ventricle, and it doesn't look overly enlarged. Well, it's big, but it's not huge. And we'll have to think about why that is. Is there something limiting how big that fourth ventricle can get? The answer is yes. And these are lateral recesses of the fourth ventricle, relative esoterica, not the meat of the material here, but if you want to go a step farther, these are the lateral recesses of the fourth ventricle. And this is the pons. And this bridge here, this connection from the cerebellum to the pons, is the middle cerebellar peduncle. There is, of course, a superior and an inferior, but this far and away has the great majority of fibers, and these are the fibers which are crossing to compensate for the fact that the cerebellum represents things ipsilaterally, and the cerebral hemisphere represents things contralaterally. Have a little band of blood there. Is that hemorrhage too? I'll bet that's, that's blood in the fissure of the cerebellum, the major fissure. And let's look up here. So we know where the blood is. We know there's mass effect, and always when there's hemorrhage and mass effect like this, it's important to measure how much midline shift there is. And I don't have that tool handy right now, but if you drag a line from here, that little prominence there where you can kind of see the falx connecting, and you go all the way back to here, which is the superior sagittal sinus in this line here, the straight sinus, then you drag a line along that, and then you see where the midline structures are displaced, and you measure how far that is. And this is way far in short summary. Okay. So huge mass effect. This is a disastrous event, of course, but it does display some important things of anatomy and pathology that we see with this kind of process, whether it's an acute hemorrhage or sometimes a tumor that has been growing over time. And you may remember that we have seen cases where we would see this tentorial incisura. Remember that? It's a little notch, and that's again because the tentorium separates the cerebral hemispheres above the tentorium from the cerebellum and brainstem below. But the tent is not just this flat thing, it's shaped like a tent. It's shaped like a tent, and so the brainstem comes up in the posterior fossa, and then you have those two cerebral peduncles that are kind of sticking up like this, and they connect to the cerebral hemispheres. The point being that this notch here, this tentorial incisura, usually has a little fluid in it, and you can see the brainstem anteriorly. You can see some CSF on top of the cerebellum, and usually it's the cerebellar vermis that you're seeing up that high in the midline. Here you have just a little bit of space, but look here. This is the tough part. The tough part is looking here and figuring out what's what anatomy is what anatomy. But it's crucial, because this hemorrhage up in the hemispheres is disastrous looking, very ominous. But the fact is, if it were smaller, or if we were able to get in immediately, just for the sake of argument, and evacuate this entire hematoma, the hemisphere could come back and there could be a great deal of recovery, because this is not hemorrhage of the brain tissue, it's kind of dissecting. These hemorrhages that are hypertensive, that arise from the perforating vessels arising from the MCA, they tend to kind of dissect apart the tissue of the brain. So this tissue here probably would ordinarily join there, and it's just spreading it apart. It's actually quite remarkable when you have a hemorrhage like this, or a smaller one. When it heals, it can heal with almost no finding at all. Once in a while on an MRI you'll have some hemosiderin causing signal abnormality showing you where the line was, but they can heal quite well. This, I think, would be less likely because of the severity of compression that would probably be not only compressing the brain tissue itself, but impairing the ability of the cerebral vessels to perfuse the brain. So I wouldn't be surprised with this much mass effect that there's probably some degree of ischemia associated too. So where are we going to look then? Massive midline shift. So phrases I would like here, I would use, because I want to communicate the sense of what's going on immediately when something like this is happening, especially. And I don't try to dance around with fancy words. There's a huge hemispheric hemorrhage on the left, and it is communicating with the ventricular system, and there's severe mass effect and midline shift. Some relatively short statement like that. And I would add that it's most likely hypertensive, because that's almost certainly what it is. But if you look down here and use your mind's eye, here we have a right lateral ventricle. This is the temporal horn of the right lateral ventricle. So if you follow it upward superiorly, you see this widening, which is the atrium of the right lateral ventricle, the atrium of the left lateral ventricle, and they ordinarily have like a little thin little horn, the occipital horn of the lateral ventricle, but that's not very well developed or demonstrated here. This is a little dilated. Ordinarily, that ventricle, even if it were an older person, if it was small to moderate in size, what happens is when you have midline shift to the right, you get cutting off of the drainage of the ventricle that you're pushing toward, and that impedes its ability to drain from the right lateral ventricle into the third ventricle. And people call it trapping of the ventricle, because the ventricle is still going to be producing CSF, and some of it will probably be getting through, but there will be an accumulation of pressure in that side because the CSF has nowhere to go. Plus, even if it weren't making CSF, the amount of midline shift is compressing the ventricle that is trapped. Okay, so that's important. Now, I would like you to be able to look at, at this level right here. I want you to look in that area. And what I see is, remember our little friend, the intrapeduncular cistern and the two cerebral peduncles? Can you see them? So here are the two cerebral peduncles. One, here's the posterior and anterior part of it. Here's the posterior part and anterior part of the other one. And this is the intrapeduncular cistern. That makes these the cerebral peduncles, and that means this little dot is probably just a tiny bit of blood that is in the cerebral aqueduct. What's poking up through here? Cerebellum. So most times we see herniation, it's downward herniation, where an event has taken place in the hemispheres, supratentorial compartment up here, and it pushes things down. But it's also possible for mass effect in the posterior fossa, inferior to the tentorium, to cause upward mass effect. And in that case, it's called superior transtentorial herniation. So ordinarily, when people refer to tentorial herniation or just herniation, they usually mean that the cerebral hemisphere is hanging over that margin. This tentorial incisura is an edge of dura, and it's the brain above that is just sitting upon it. But if it is to herniate downward, which actually is happening here, then that's called transtentorial herniation. But in this case, we also have a mass effect in the posterior fossa because of this blood in the fourth ventricle, which is not a huge amount, but there's also subarachnoid blood in the prepontine cistern and in the intrapeduncular cistern. Now there you can see more clearly the intrapeduncular system in the cerebral peduncles, and if you go up one level higher, it's smooched. Why? This is the temporal horn of the left lateral ventricle. It's too far medial. Let me get down to the normal size here. It's too far medial. That's because this hemorrhage is just pushing it that way. It's pushing the cerebral hemisphere at this level, which is temporal lobe, medially. And the medial part of a portion of the temporal lobe is called the uncus, U-N-C-U-S, and it's around here. And it's there where the temporal lobe is kind of sitting along the tentorium, that this uncus of the medial temporal lobe can push over medially and then hang down. And here again, if we look there, even though it's not ideal, you can see maybe that you have a lobule of tissue coming from the temporal lobe. Here you can see the medial aspect of the temporal lobe. It's up against the midbrain, or the cerebral peduncle here, this margin here, and then it goes ba-doop, like that. And here's the tentorium. So this part is the medial part of the temporal lobe, and it's pushed medially, and that's what's squashing this midbrain. The midbrain specifically at the level of the cerebral aqueduct and the cerebral peduncles. And if you look here, what you see here that may not be as striking is the fact that the midbrain is pushed over to the right. And this goes back to the subject I was alluding to before. You can have gangbusters of hemorrhage up here in the hemispheres and still survive and recover a great deal of your function if intervention is early and successful. But when it comes to brainstem compression, it is immediately life-threatening. You see signs like pupillary dilatation and complete unresponsiveness, and those are effects of brainstem compression, and that's life-threatening. Respiration can be compromised, even heart rate can be erratic. So that's the big take-home point here, is that you have this gangbusters, huge hypertensive hemorrhage in the left cerebral hemisphere with lateral ventricular extension and severe midline shift. And the blood goes into the third ventricle, which itself is displaced to the right. And it takes a lot more pressure to displace that third ventricle, which is more inferiorly positioned and well anchored than the hemisphere itself and the interhemispheric fissure, which is what we usually see midline here that's pushed over. On top of that, though, you have this herniation here, and it's tough. And the reason being that the structures that are usually nicely defined by the fluid in the subarachnoid space, the cisternal fluid that is occupying the quadrigeminal cistern here, which would be adjacent to the quadrigeminal plate or the colliculi, the intrapeduncular system, which is filled with blood here, and then there's an ambient cistern that goes out laterally here. They're all effaced. They're all just squashed. Everything is very, very tight there. And that's why it makes it hard to see what I hope you can at least begin to see. And I know it's probably very hard if you haven't looked at many of these cases, but this is a line defining temporal lobe from cerebellum. And usually, you remember, we can see that very nicely because there's fluid intervening there too. Here's the left temporal lobe, and it has moved medially. And it can be hard to see that, but if you look here, what do we have? This is the sella turcica. This is the dorsum sella. This is the dorsal aspect of that saddle-like structure, the sella turcica. And so this is midline here. Well, if you drag something like from that to here, you can see this temporal lobe is much closer to the midline than this one. And that uncal, UNCAL, herniation of the medial temporal lobe is causing brainstem compression, specifically at the level of the midbrain and the cerebral peduncles. And there's also a certain degree of downward pressure that together is pushing the midbrain over to the right and also pushing down on the cerebellum, while at the same time this blood in the fourth ventricle is making the cerebellum want to move up. So we have superior transtentorial herniation here of the cerebellum going upward because of the posterior fossa hemorrhage and mass effect, and you have normal, kind of the more typical transtentorial herniation, which is medial temporal lobe or uncal herniation that's coming from the supratentorial compartment down over the tentorial incisura and pressing on the brainstem. Well, I think that's enough for this case.